Good morning, class. I'm Dr. Sovit from ENT department CMC. Today, I'm going to teach you about clinical anatomy of middle ear. I hope you all are listening to me. Okay, let's start. Middle ear anatomy, clinical anatomy is very important in the from exam point of view and also for the any ear surgery. So you should carefully listen to this lecture and have a strong grip on clinical anatomy of middle ear. So let's start. In today's class, we'll learn something about embryology of middle ear, walls of middle ear, contents, spaces of middle ear, muscles in middle ear, blood supply, nerve supply, and some miscellaneous things about middle ear. Okay, now let's see. This is the picture of middle ear. You can see this is external ear, middle ear, eardrum, also called tympanic membrane, the inner ear, housing the cochlea. This is tympanic membrane, ossicles, muscles. This is middle ear cavity. This is auditory tube. This overall picture of middle ear. Now again, this is the same thing. External ear, pinna, tympanic membrane, ossicles, middle ear, Eustachian tube. Okay, this is a realistic painting of middle ear. The half of tympanic membrane has been stripped off. Ossicles are seen. Again, the Eustachian tube. Okay, now middle ear cleft. When we talk about middle ear, we talk as a middle ear cleft as a whole. Middle ear cleft consists of the first, the Eustachian tube, also called the auditory tube or pharyngotympanic tube, and the tympanic cavity or the middle ear cavity. Middle ear or middle ear cavity or tympanic cavity consists a part of middle ear cleft, and there is adductus which connects this middle ear cavity or tympanic cavity towards the antrum. Another thing is mastoid antrum and the all mastoid air cells interconnected with the mastoid antrum. These four things constitute middle ear cleft. Now the embryology, just like all the structures of head and neck arise from this pharyngeal arches, pharyngeal pouch and pharyngeal cleft. Middle ear basically arise from the first pharyngeal pouch. So endoderm, it grows into tubotympanic recess. The development of middle ear starts from 3rd week and is complete by the 30th week of gestation. Now from the first pharyngeal pouch, the endoderm arising from the pouch extends superolaterally. It forms the Eustachian tube or the pharyngotympanic tube, also called auditory tube. And it also expands to form the middle ear cavity, and further it extends to form mastoid antrum. Now the mesoderm of the first pharyngeal arch, they form Malleus, Incus. These two ossicles, Malleus and Incus, arises from the first pharyngeal arch, which gives rise to the Meckel's cartilage. So Meckel's cartilage develops into ossicles, Malleus and Incus, and also the muscles, tensor tympani muscles and the ligaments of the ossicle Malleus. Now the second pharyngeal arch, the mesoderm of second pharyngeal arch give rise to Richard's cartilage, gives origin of Stapes and the stapedius muscle. And the first pharyngeal membrane, when the first pharyngeal pouch and pharyngeal cleft, they extend and they thin out the mesoderm and a membrane forms. The first pharyngeal membrane, this membrane gives origin to the tympanic membrane. So from first pharyngeal pouch, Eustachian tube, middle ear cavity and mastoid antrum, first pharyngeal arch gives origin to Malleus and Incus, and second pharyngeal arch to Stapes and the Stapes muscle. Now this is the picture. This is the Meckel's cartilage or the Mesoderm of first pharyngeal arch gives rise to Malleus and Incus. Stapes arises from the second pharyngeal arch. Now this is the first pharyngeal groove or cleft. This is first pharyngeal pouch. They extend, and in the middle they form the tympanic membrane. The inner ear arises from the neuroectoderm. These are the ossicles developing from the mesoderm of first pharyngeal arch, Malleus and Incus. Stapes arises from the mesoderm of second pharyngeal arch. This is the same ossicles and the mesoderm. The first pharyngeal cleft and pharyngeal pouch give rise to the first pharyngeal membrane. That's why tympanic membrane consists all three germ layers: the ectoderm, the endoderm, and the mesoderm. Now, what embryological anomalies can occur when the development is disturbed somehow? There may be malformed ossicles, ossicular agenesis, there would be no ossicles or Malleus Incus fusion, ossicular mass, incudus-spadial joint disarticulation, all affecting the hearing, and also the facial nerve anomalies. And it may also give rise to the stapedial artery, the artery which should degenerate, but it persists, persistent stapedial artery. These are the embryological anomalies in the development of middle ear. Now let's come to the pharyngotympanic tube, Eustachian tube. It is a long tube. It has got divided into two parts. The bony part is lateral. The superior 1/3 consists of bony part. The medial 2/3 is fibrocartilaginous. And the junction between these two parts, bony and cartilaginous part, is narrowed junction. It's called isthmus, the narrowest part of the whole tube. Now the cartilaginous part or fibrocartilaginous part consists of an incomplete ring of cartilage. Posterior medially, it's located cartilage plate. It has got two lamina, lateral lamina, medial lamina, connected by elastic band. And anterolaterally, it is deficient. So it is closed by a fibrous tissue and a fat pad called Ostman's fat pad. This is the cartilaginous part of Eustachian tube. Now there is difference between the Eustachian tube in adults and infants. In this chart, just see the length is longer, 36 millimeter, and 18 millimeter in infants, and the angulation with the horizontal, it's a 45 degree in adult and 10 degree in infant. So in infant, the tube is almost horizontal, and the lumen is narrow in adult, wide in infant. Angulation at isthmus present and absent in infant, and the cartilage in adult is rigid and in infant is flaccid. Elastic recoil is also effective in infant, ineffective. Ostman fat is more in adult, and in infant it's less. The reason for explaining these two differences occur in showing you that the adult Eustachian tube is much better in functioning than in infants. That's why in infants there is high chances of upper respiratory tract infection entering the middle ear and causing the middle ear inflammation. So these are the differences between the adult Eustachian tube and infant Eustachian tube. The length is longer, the angulation is more steep in adult, lumen narrow. In all these factors, adult Eustachian tube is more effective and more functional than in infant. Now the blood supply of Eustachian tube is by ascending pharyngeal artery. This is a branch of external carotid artery, middle meningeal artery, artery of pterygoid canal, and all the venous drainage goes to the pterygoid venous plexus. Now, tympanic membrane, eardrum. The characteristic of tympanic membrane, its color is pearly white or pearly gray, and it's not transparent, not opaque, it's semi-translucent membrane. So we can see the shadows of the things in the middle ear through the tympanic membrane. We cannot see them clearly, and the view is not completely obstructed, but we can see the shadows. And the tympanic membrane is oriented not quite vertically. When it is obliquely placed, anteriorly it goes inwards, and inferiorly it goes inwards. So it is tilted, obliquely placed. And it has got two parts, pars tensa, a tense part, pars tensa, and the flaccid part, pars flaccida. This is pars flaccida, this is pars tensa. And in pars tensa, there are three layers, as we talk in the embryology of development of middle ear: the outer epithelial layer, inner mucosal layer, and the middle fibrous layers. This is the otoscopic picture of left tympanic membrane. Now the fibrous layers, in the difference between pars flaccida and pars tensa is that in pars tensa, the middle fibrous layers is well organized. There are well organized fibers, concentric fibers, radial fibers, parabolic fibers, all organized, giving it the tensile strength. But this is deficient in pars flaccida. In some books, they say there is no fibrous layer in pars flaccida, but recent books, they say there are fibers, but they are disorganized. That's why the pars flaccida is flaccid, not as tense or strong as pars tensa. Now the tympanic membrane. Now the landmarks in tympanic membrane, otoscopic vision of this tympanic membrane. This is the handle of Malleus, and due to the orientation of the tympanic membrane, it is obliquely inclined anteriorly inwards and inferiorly inwards. So there is the reflection of the light of otoscope. This is the reflection of light of otoscope, also called cone of light. So along the handle of Malleus, the tympanic membrane, especially the pars tensa, is divided into 4 quadrants. This is obliquely, the axis is along the handle of the Malleus. There are 4 quadrants, superior 2, inferior 2. The pars flaccida is also called Sharpnell's membrane. And another difference between the pars tensa and pars flaccida, this pars tensa, the margin of pars tensa is thickened into fibrocartilaginous annulus. This thickening at the rim of pars tensa is called annulus. This fits into the tympanic sulcus of the temporal bone. This annulus is deficient in pars flaccida. And this notch of the EAC, the temporal bone, notch of this EAC, where this pars flaccida fits, where there is no annulus, is called the notch of the Venous. Now this is the cone of light. Cone of light is in normal TM is located in the anterior-inferior quadrant. This is the left tympanic membrane. This is handle of Malleus. And since the tympanic membrane is semi-translucent, we can see the structures in the middle ear through the shadows, not the structures, but the shadows of these structures through the tympanic membrane. As here you can see, this is the shadow of the Eustachian tube here. And you can see the Incus and Stapes, shadow of Incus and Stapes. This area is a round window. And this is the lateral process of Malleus. Now, nerve supply of tympanic membrane, the anterior half is supplied by auriculotemporal nerve, and the posterior half is supplied by the auricular branch of vagus nerve. This is the lateral surface, the outer surface of nerve supply, sensory supply is given by auriculotemporal nerve in the anterior half and the vagus in the posterior half, and the medial surface is supplied by glossopharyngeal nerve. The branch of tympanic branch, which is called Jacobson's nerve, supplies the medial surface, whole of the medial surface of the tympanic membrane. Now the tympanic cavity, let's come to the middle ear cavity or the tympanic cavity. This cavity is actually not exactly a box shape, but it's a biconcave disc shaped. The vertical diameter is 15 millimeter, anterior posterior diameter is 15 millimeter, and the transverse diameter varies. Superiorly it is 6 millimeter, in the middle is 2 millimeter, and inferiorly it is 4 millimeters. So tympanic cavity is a biconcave disc shaped box. Now the communications of the, now we can divide the middle ear, the tympanic cavity, into 3 compartments: epitympanum, mesotympanum, and hypertympanum. And the The demarcation starts from the upper and the lower margin of the tympanic membrane. This portion superior cavity is called epitympanum, also called attic. The inferior compartment is called hypertympanum, and the part of the middle cavity parallel to the tympanic membrane is called mesotympanum. This is how middle ear cavity is divided. Now, communication of middle ear cavity. Anteriorly, it is communicated to Eustachian tube, and Eustachian tube opens into the nasopharynx. And the posteriorly, it communicates to the adductus, and through the adductus to the mastoid antrum and mastoid ear cells. And all the opening on the only entrance of ear to this, access to this tympanic cavity in normal ear is through the Eustachian tube. There is no other entry point to the middle ear cavity except Eustachian tube. Now, walls of middle ear, tympanic cavity walls, will now convert this middle ear into a six-sided box, a shoebox structure for simplification. So we have 6 walls: lateral, medial, roof, floor, anterior, and posterior wall of middle ear. And there are certain structures in these walls which are very important. And this picture is also very important from exam point of view. So let's start with the lateral wall. This is the simplified picture for explaining the walls of middle ear. Now let's start with the lateral wall. Lateral wall, it consists of tympanic membrane, which forms the membranous part of the lateral wall, and the bony wall. Bony wall is formed, lateral wall is formed by the lateral attic wall above the pars flaccida. This is also called scutum, and the lateral wall of the hypotympanum. So this forms the lateral wall of tympanic cavity. And there is a nerve, chorda tympani, which crosses the lateral wall between the long process of incus and the malleus, medial to the malleus. Now this is the lateral wall. So see, this is the tympanic membrane. This is the biconcave cavity. This lateral wall is formed by the tympanic membrane, and superiorly it is formed by the scutum. Scutum is nothing but the bony wall of the outer wall of the attic or the epitympanum. This is the epitympanum region. This is the bony lateral wall, and inferiorly this is the lateral wall of hypotympanum. So this whole consists the lateral wall of middle ear. Just see here, this is the inside view of tympanic membrane. This is a parasagittal section. This is the inside of the tympanic membrane, handle of Malleus. So this forms the lateral wall tympanic membrane, and behind this head of Malleus and body of Incus, there is scutum. And the nerve chorda tympani just passes between the Incus and the Malleus, crosses the lateral wall. So lateral wall, just simple. Tympanic membrane, scutum, lateral wall of hypotympanum, and chorda tympani nerve. Now the medial wall, the most important wall of middle ear, medial wall. It has promontory. It is the balls formed by the basal turn of cochlea. There are 2 fenestra, 2 windows, oval window, also called fenestra vestibuli. This is covered by the Stapes footplate and annular ligament. The round window, another window, also called fenestra cochleae. This is covered by the secondary tympanic membrane. The membrane covering the round window is secondary tympanic membrane. And also in the medial wall is tympanic part of facial nerve canal. Facial nerve inside its bony canal passes through the medial wall, the tympanic part or the horizontal part. And this facial canal is also called fallopian canal. And there is another bony projection, hook-like bony projection called processus cochleariformis in the medial wall. This houses the tendon of tensor tympani muscle. And another important structure in the medial wall is the prominence of the dome formed by the lateral semicircular canal. Now this is the medial wall. The structures is the dome of lateral semicircular canal. It's a tympanic part of facial nerve in bony canal, also called fallopian canal. This is oval window covered by the Stapes footplate. This is round window covered by the secondary tympanic membrane. And here is processus cochleariformis, a bony projection which houses the tendon of tensor tympani muscle. And the promontory, the large bulge formed by the basal turn of cochlea. In this realistic picture, this is promontory, this is oval window covered by the stapes foot plate, this is round window, this is bulge of lateral semicircular canal, and this is facial nerve, fallopian canal, the tympanic segment of facial nerve. And here is the processus cochleaformis. Now, roof. Roof is also very simple. It is formed by the tegmen tympani, a thin plate of bone, hard bone, separates this tympanic cavity from the middle cranial fossa. From the intracranial cavity, the thin plate of bone forms the roof. And this roof extends posteriorly to form the roof of antrum, also called tegmen antri. Now, this is the real picture of temporal bone. This is the tympanic cavity. This is tympanic membrane, malleus, incus, and the roof. This is the roof of middle ear, tegmen tympani, and this is antrum. This is roof of antrum, tegmen antri. This sheet of bone separates middle ear cavity from the middle cranial fossa. So tegmen tympani forms the roof of this box middle ear cavity. Now the floor. Floor is also simple. It is formed by the thin plate covering the jugular bulb. This separates hypotympanum, the middle ear cavity, from the jugular bulb. There's a thin bone. Sometimes it is dehiscent. So only a mucous membrane of middle ear cavity covers the jugular bulb. So during surgery, you can injure the jugular bulb. And also the another nerve passes through the floor. This is tympanic branch of glossopharyngeal nerve. Pierces the floor between the medial and the floor, medial wall and the floor of the middle ear cavity. This is the tympanic branch of glossopharyngeal nerve. Now the anterior wall divided into upper part and the lower part. The upper part, the muscle, tensor tympani muscle. There is a canal housing this muscle. So in upper part of anterior wall is the canal for tensor tympani muscle and the opening of the Eustachian tube. Eustachian tube opens into the upper part, superior part of the anterior wall, not in the inferior part. And the lower part, there is a thin plate of bone, again separating the internal carotid artery from the middle ear cavity. Sometimes also this anterior wall separating the carotid artery, internal carotid artery is dehiscent, also giving risk of injury during the surgery. And there is another, in anterior wall, there is an opening also called anterior canaliculus, through which this chorda tympani nerve exits the middle ear cavity. And also these sympathetic fibers from this sympathetic plexus of nerves around the internal carotid artery pierces the anterior wall to enter the middle ear cavity. Now this is the anterior wall. This is the cross-sectional, not cross-sectional, this parasagittal cuts. This is the anterior wall. This is upper part. This is canal for tensor tympani muscle, and this is opening of the Eustachian tube. And here lies the internal carotid artery, thin bone separating internal carotid artery and the hypotympanum. And this is the exit of the chorda tympani. This exit is called anterior canaliculus and also called canal of Fugger. Now the posterior wall has an opening called additus and antrum, the opening which leads to the mastoid antrum. And inferior to the additus, there is fossa incudis. There is a cavity. There is a cavity where the short process of incus lies. And also, just like in medial wall of the tympanic cavity, there is bulge produced by lateral semicircular canal. Even in the posterior canal, there is pyramidal eminence. In the posterior wall, there is a pyramid type of bony eminence which houses the stapedius tendon. And there is also the bulge produced by the vertical part of facial nerve. In the medial wall, there was bulge produced by the horizontal or the tympanic part of the facial nerve. In posterior wall, there is the vertical part of facial nerve. And also the posterior canaliculus where the chorda tympani nerve arises. And there are cave-like structures, cavities in the posterior wall, 2 cavities, sinus tympani, and the facial recess. This is the posterior wall, additus, and somewhere here inferior to the additus is the fossa incudis, and then this is the vertical part of facial nerve. This is pyramidal eminence, gives rise to the tensor tympani, stapedius muscle tendon, and this is the entry point of chordae tympani nerve, also called the posterior canaliculus. And in this picture, you can see this is the posterior wall. The anterior wall is cut off. This is lateral wall. This is medial wall. This is the posterior wall. This is the opening. Additus. This is fossa incudis. This is bulge of semicircular canal, lateral semicircular canal. This is vertical part of facial nerve, and this is pyramidal. This is pyramidal eminence, giving rise to the stapedius tendon. And this is the entry point or the anterior canaculus for chordae tympani nerve. Now the facial recess in the posterior wall, it is nothing but a depression on the posterior wall, which is lateral to the pyramidal eminence. Medial boundary is facial nerve, lateral is chordae tympani, and superiorly there is fossa incudis. This is the fossa incudis. Laterally chordae tympani, medially is the facial nerve. This area is called the facial recess. The importance of facial recess is that we can reach the middle ear in middle ear surgery without raising the tympanic membrane. This is the posterior entry to the medial wall. Gives direct access to the middle ear without disturbing the EAC, canal wall. Now again another cavity, sinus tympani. So medially is the medial wall of the middle ear, and lateral is the pyramidal eminence, superiorly is the ponticulus and subiculum. This ponticulus and subiculum are nothing but bony ridges in the medial wall of the middle ear cavity, and this can extend deep till 9 millimeter into the mastoid. This is the sinus tympani. This is the pyramidal eminence. It's the facial nerve. Facial recess is lateral to the pyramidal eminence, and sinus tympani is medial to the facial nerve. Pyramidal eminence is sinus tympani. The importance of this sinus tympani is that disease can hide inside this sinus tympani, which is inaccessible, and through the operating microscope we cannot visualize this area, so we can leave the disease there during the middle ear surgery. This is the importance of sinus tympani. Now this is an endoscopic picture. This depression cavity is sinus tympani. This is the pyramidal eminence. This is the tendon of stapedius muscle. It's a facial nerve. And this is deep inside is the sinus tympani, medial to the facial nerve. Deep to the facial nerve is sinus tympani, and the facial recess is lateral to the facial nerve. Now let's come to the contents of middle ear. There are 3 ossicles, Malleus, Incus, and Stapes. The 2 muscles, tensor tympani muscles and stapedius muscle. The nerves are chordae tympani nerves, and the plexus of nerves also called tympanic plexus in the medial wall especially, but it also is divided as a contents of middle ear, tympanic plexus formed by different branches of nerves, different nerves, and also ligaments and mucosal folds. These are the contents of the middle ear, and above all, air is the main content of the middle ear. Middle ear, there's no fluid, no blood, no plasma, no any fluid, but there is air inside the middle ear. Now let's come to the ossicles. There are 3 ossicles you must be knowing: Incus, Malleus, Incus, and Stapes. Malleus is also a hammer. This is the hammer, and the Incus is anvil, and Stapes is likened to compared to the stirrup due to its peculiar shape. Now let's come to the Malleus. This is the largest of all 3 ossicles. It has part, head, neck, handle, lateral and anterior processes. 2 processes, lateral and anterior processes. Anterior process is also called short process. the handle, the head, and the neck. Head and neck of Malleus, it rests in epitympanum, rests in the handle, rests in the lateral process, and the process is in the mesotympanum. Now, this Malleus is suspended by ligaments, suspensory ligaments. Superior it is attached to the roof with superior malleal ligament, anterior with anterior malleal ligament. Lateral process and anterior process of this, they receive the folds from the tympanic annulus. The tympanic annulus, instead of going towards the pars flaccida, it just converges towards the malleus and forms the lateral, anterior and posterior malleolar fold. This also forms a ligament that hangs the malleus. And this malleus articulates with the incus in a saddle type of synovial joint. Small synovial joint, the saddle type articulates with the another bone, incus. Now this is the incus, this is the head, this is neck, this is handle, this is anterior process, this is lateral process. Anterior process, lateral process, head, neck, and the handle. Size is around 8 millimeter. Now let's come to incus. Incus has a body and two processes and lenticular process. This is body, this is short process, this is long process, and this is lenticular process. This lenticular process articulates with the head of stapes, and again this joint is a synovial joint and ball and socket type of joint. This is the articulatory facet with the malleus. Head, short process, long process, lenticular process. Now stapes, it has head, neck, and the two crurae, anterior and the posterior crurae. Posterior crurae is thicker than the anterior crurae, and a foot plate. All two ossicles, Malleus and Incus, arises from the first pharyngeal arch. Stapes arises from the second pharyngeal arch, except the foot plate, which arises from otocyst. Foot plate and the annular ligament encircling the foot plate. That's the smallest bone in the body. Now let's come to the intratympanic muscles. There are two muscles, tensor tympani muscles and the stapedius muscles. Tensor tympani muscles originate from the cartilaginous part of Eustachian tube. It inserts into the upper end of Malleus. Inserts into the upper end of Malleus, and the nerve is supplied by the mandibular nerve, the third trigeminal branch. The action of tensor tympani is it tenses the tympanic membrane. When it gets activated, it tenses the tympanic membrane. The tensor tympani muscle is derived from the first pharyngeal arch, so this mandibular nerve, the V3, supplies this tensor tympani nerve. Now the stapes, this origin is pyramidal eminence, inserts into the neck of the stapes, and this stapedius muscle is supplied by the facial nerve, branch of facial nerve. And the action of stapedius muscle is it tilts the foot plate in the oval window. It stiffens the foot plate. The tensor tympani stiffens the tympanic membrane. Stapedius muscle stiffens the foot plate. These both are involved in the protective reflexes. When loud noise is heard and much of mechanical energy is transferred to these ossicles, they try to compensate it by tensing all these muscles and making the foot plate tense and the tympanic membrane tense. Stapedius muscle, just like stapes, arises from the second pharyngeal arch, so it is supplied by the nerve of second pharyngeal arch, which is facial nerve, seventh nerve. Now in this picture, this is the tensor tympani muscle. It arises from the cartilaginous part of Eustachian tube, travels through a canal provided for it, opens through in the anterior wall, and it hooks around the bony projection, processus cochlear formis on the medial wall, and the cochlear processus cochlear formis acts as a pulley. So after it comes out of this processus cochlear formis, the tendon, it comes outwards and attaches to the handle of the malleus at the upper part. This is the tendon of tensor tympani muscle. This is endoscopic picture inside of tympanic cavity. This is anterior wall, this is lateral wall, this is medial wall. Just see, this is the tensor tympani muscle arising from the canal in the anterior wall. It goes through. Here is the prosum behind this handle of Malleus. Incus is the process cochleaformis. From then it turns in the right angle, gives rises to the tendon. This tendon attaches to the handle of Malleus. So whenever it gets activated, the handle of Malleus is pulled inside, and in the handle of Malleus is attached this tympanic membrane. So it retracts the tympanic membrane and makes it tense. Similarly, the stapedius muscle arises from the pyramidal process. This is the tendon, attaches to the neck of the stapes. This is stapedius muscle. Now again in this picture, this is the tensor tympani muscle traveling above the Eustachian tube from where it hooks. This processor cochleaformis, and tendon attaches to the neck of handle of Malleus, and this is the stapedius muscle arises from the pyramidal eminence. The tendon attaches to the neck of stapes. Now the nerves, chordae tympani nerves. It enters the posterior wall, the middle ear cavity through the posterior wall. The entry point is called posterior canaliculus. It travels across the medial surface of the TM that forms the lateral surface of tympanic cavity. Medial surface of the TM is medial to the handle of Malleus. That means in between the incus and the Malleus, and travels above the tensor tympani muscles, and it exits through the anterior canaliculus in the anterior wall of the middle ear, ossicle canal of Gear. And this chordae tympani carries the special sensory fibers, the taste sensations, from the anterior two-thirds of the tongue, and also the autonomic fibers, secretomotor fibers, to the submandibular and sublingual glands. And now the tympanic plexus. This is the north plexus over the promontory in the medial wall. This is formed by the Jacobson's nerve. It's a branch of glossopharyngeal nerve, tympanic branch of glossopharyngeal nerve, and the lateral petrosal nerve, and the caroticotympanic nerves from the sympathetic plexus around ICA. The sympathetic plexus around the ICA enters the middle ear through the anterior wall and joins to form this plexus, joins this Jacobson's nerves and the lateral petrosal nerves. So this is the tympanic plexus over the promontory. Now the blood supply of middle ear. These are mainly supplied by the middle meningeal artery, maxillary artery, the branch of external carotid artery, internal carotid artery, and the ascending pharyngeal artery and posterior auricular artery. The middle meningeal artery gives the two branches, superficial petrosal artery and the superior tympanic artery. The maxillary artery gives rise to the anterior tympanic artery. This is a maxillary branch of maxillary artery is the anterior tympanic artery. Internal carotid artery gives a caroticotympanic branches. Ascending pharyngeal artery gives inferior branches, and the posterior auricular artery, stylomastoid branch. Hello. Hello.
Yes, sir. Hello.
Hello. Suni Rachu.
Hello.
Hello. Suni Rachu.
Yes, sir.
Yes, sir.
Any video आइरा छ?
तपाईको फोटो आइराछ सर.
भिडियो
छ सर आइराछ.
आइराछ सर.
मेरो आइरा छ कि स्लाइड को यो कम्प्युटर को?
तपाईको.
ए पक्का त एकैछिन. Stop video, share screen. आयो भिडियो?
Yes, sir.
Yes, sir.
ल सुरु गरौँ है त फेरि. Okay, now we are in blood supply. Blood supply of the middle ear. By middle meningeal artery, two branches, superficial petrosal and the superior tympanic artery, and from the internal maxillary artery via anterior tympanic artery, directly from the ICA, internal carotid artery, and from the ascending pharyngeal artery, this is posterior tympanic artery, and through the posterior auricular artery through stylomastoid artery. So these are the main branches supplying the middle ear, arterial branches. Now the venous drainage. The venous drainage is towards the plexus of veins, pterygoid plexus of veins, and the superior petrosal sinus. Lymphatic drainage, lymph drain into retropharyngeal lymph nodes, preauricular parotid lymph nodes, and the upper deep cervical lymph nodes. This is the lymphatic drainage, and the venous drainage is pterygoid plexus of veins, the superior petrosal sinus. Now the mucosa of the middle ear. The middle ear is lined by mucosa. This is the respiratory mucosa with mucus secreting function, and these are somewhere pseudo columnar, pseudo stratified columnar, or sometimes cuboidal. But these are the respiratory mucosa with cilia and the mucus secreting glands. There are three mucociliary pathways for clearance of mucus towards the Eustachian tube, the epitympanic pathway, the promontorial, and the hypertympanic pathway. These all path, the cilia in this part, they beat towards the opening of the Eustachian tube, forcing the mucus drainage towards the Eustachian tube. And from Eustachian tubes, it comes to the nasopharynx. This is the cleaning mechanism of the middle ear by the middle ear mucosa lined by the respiratory mucosa. And this mucosa also lines, it wraps the ossicles, the ligaments, all the cavities, and all the muscles in the middle ear. All the contents of middle ear is lined by this middle ear mucosa. It forms different folds, dividing the middle ear into different cavities or compartments. Now let's talk about the attic, also called epitympanum. It's just like the attic of the house. This is situated above the margin of the tympanic membrane. The contents of the attic or the epitympanum is head of Malleus and the body of Incus, body and short process of Incus, and the includomalleolar joint, the joint between the Incus and the Malleus. And this head of the Malleus and the body of Incus with the joint divide the attic into the two parts, medial and the lateral parts. Because of the head of Malleus and body of Incus occupying the most space of the attic, this attic area or the epitympanic cavity area is difficult to access, so there might be residual polystoma, the disease after surgery. So attic is the difficult part for the surgery. And also the attic, the ventilation is very narrowly provided, so after the surgery, due to the resorption of the air inside the attic and the stoppage in the ventilation, there might be the retraction of the attic and disease might develop. So this area is called attic. This is attic of the middle ear, also called epitympanum. This is head of Malleus, body of Incus, short process occupying the most of the area, poorly ventilated area. The outer wall of the attic is also called a scutum, which forms the bony part of the lateral wall of middle ear. This hypertympanum. Now the mastoid antrum. Mastoid antrum is the largest air cell in the mastoid air cell system. So this is connected to the middle ear through the adductus. The roof of the antrum is formed by the tegmen antri. This is the continuation of the tegmen tympani, the roof of the tympanic cavity. This is the tegmen antri. This is antrum. This whole bone is the temporal bone. This is the mastoid part of temporal bone. These are the mastoid air cells, just like a honeycomb. The lateral part of the mastoid antrum is formed by the plate of bone. The outside part of the antrum is formed by the bony plate called, this is surgically marked as MacEwen's triangle. The floor of the antrum, it opens into the mastoid air cells. All the mastoid air cells communicate to the mastoid antrum through the floor. And then it communicates to the tympanic membrane and through the, tympanic cavity and through the Eustachian tube towards the outward. So air passes from the pharynx, Eustachian tube, middle ear, then antrum, then all this mastoid air cell system. So this is the MacEwen triangle. Superiorly, the MacEwen triangle is line bordered by the temporal line. This is the temporal line. This gives the division between the middle cranial fossa and the middle ear. It's the temporal line. The anterior boundary is formed by the posterior superior part of ear canal, external auditory canal, the posterior superior part, top part, and the posterior wall is formed by the boundaries formed by the a line tangent to the external auditory canal, starting from the midpoint of this posterior canal. So this is the MacEwen triangle. This also contains the spine of Henle. This is spine of Henle. The significance of MacEwen triangle in surgery is that just below this triangle lies the mastoid antrum. So when we do the surgery of ear, or we have to, the disease in the mastoid antrum, we need to enter the mastoid antrum first. We drill in this triangle. So straight away we can reach the mastoid antrum. Mastoid antrum lies 12 to 15 millimeter, approximately 12 to 15 millimeter deep to this triangle, MacEwen triangle. Now, mastoid bone, it consists of bone cortex and air cells, just like a honeycomb. This both develops, a mastoid bone develops from the squamous and the petrous bone of the temporal bone. And the suture, when persists between this squamous and petrous bone, it forms a very hard plate called corner septum, separating the superficial squamosal and the deep petrosal cells. So this is also important from the surgical point of view. So when we encounter corner septum, we have to drill through it to get into the deep petrosal mastoid air cells. Corner septum only occurs when there is persistent petrosquamous suture. It doesn't occur normally. And there are three types of mastoid. During the pneumatization of the mastoid, development of air cells in the mastoid bone, there are three divides mastoid into three types. One is well pneumatized, well cellular, well developed cells within the and with thin intervening septa. The septa between the cells are very thin, just like a honeycomb. This is well pneumatized mastoid. And diploic mastoid, where all these spaces, instead of air, they are filled with bone marrow. And the third type is sclerotic or acellular. There are no spaces, cells or marrow spaces, nothing, just bone, hard bone. This is called sclerotic. Now, depending on the location of these cells, they are grouped into different categories. Zygomatic mastoid air cells along the zygoma, tegmen along the tegmen, tympani and tegmen antri, perisinus around the sigmoid sinus, retrofacial behind the facial nerve, perilabyrinthine in the medial wall, peritubal around the Eustachian tube, at the mastoid tip, and the marginal and the squamosal part. These are the different groups of mastoid air cells. The source of air in all these mastoid air cells is through the mastoid antrum. The only way the air enters the mastoid air cell system is through the Eustachian tube. Now the Prussak space, another surgically relevant space, Prussak space. This is a very small space but very important space. The medial boundary is the short process and the neck of the Malleus. This is the neck of the Malleus and the short process. The medial boundary, lateral is the tympanic membrane, the shrapnel's membrane, the pars flaccida, lateral membrane boundary is formed by the shrapnel's membrane and the bony annulus, the notch of Venous. Anteriorly by the anterior malleolar fold and the anterior malleolar ligament, the ventilation of this Prussak space, small closed space, is through a tiny opening in the posterior part. There is no any other way for air to enter this space. So when there is a retraction of pars flaccida, the ventilation stops and the pars flaccida retracts into this Prussak space, forming a cholestatoma, and the cholestatoma can spread anterior to the handle of the Malleus. The disease may arise in this space and continue anteriorly to the handle of the Malleus. This is the relevance of Prussak space. Now, lastly, the surgical landmarks of facial nerve. During the ear surgery, we need to, the facial nerve is housed in the bony canal called Fallopian canal. We can see the facial nerve directly. We can see the bulge of facial nerve, different parts of facial nerve, but there are some certain landmarks through which we can identify the facial nerve. The first one is processus cochleariformis, the hook-like projection, bony projection in the medial wall of the tympanic cavity. It arises to the tendon of tensor tympani muscle. The facial nerve lies just superior to processus cochleariformis, and the tympanic part starts at the level of processus cochleariformis anteriorly. And the oval window and the horizontal canal. The oval window is just inferior to the second genu of the facial nerve canal. The second genu is where the facial nerve horizontal part or the tympanic part of the facial nerve turns inferiorly and forms a knee-like structure genu. The oval window is just inferior to that genu or the tympanic part of the facial nerve. And the horizontal semicircular canal, the bulge of lateral semicircular canal, is superior to the facial nerve. So you can say the facial nerve, the genu runs between the oval window and the bulge of the lateral semicircular canal, also called horizontal canal. And also the short process of incus. The facial nerve is deep to the short process of the incus, which is housed in fossa incudis in the posterior wall of middle ear cavity. So we cannot reach the facial nerve until we reach the short process of incus. So in the ear surgery, when we are drilling the bone, when we are superior or superficial or above the incus short process, then we are safe that we won't be injuring the facial nerve. And again, the pyramid, the bony eminence in the posterior part, the facial nerve just lies deep to the pyramid. And the digastric ridge, this is the ridge inside the mastoid cavity, which gives rise to the digastric muscle. The inside portion is, there is a ridge, and the facial nerve, the vertical part of the facial nerve just lies deep to this digastric ridge, deep or medial. So these are the landmarks: processus cochleariformis, oval window, horizontal canal, short process of incus, pyramid, and digastric ridge. This is the facial nerve. This is the first genu. Now then it enters the middle ear cavity along the medial wall in the bony canal. This is the tympanic segment or the horizontal segment of the facial nerve. This is the hook-like projection, processus cochleariformis. The facial nerve is superior to the processus cochleariformis, around 2 millimeters superior. Then the facial nerve turns and continues vertically downwards at the second genu. The second genu is between the bulge of lateral semicircular canal, the medial wall, and the oval window covered by Stapes footplate. And this is the vertical section, and this is middle to the digastric ridge, the mastoid tube. In the endoscopic real picture, inside of the mastoid cavity, this is the processus cochleariformis, giving rise to the tensor tympani tendon attached to the neck of the malleus. And this is the facial nerve, seventh nerve. It just lies just above the processus cochleariformis. And this is the stapes, this is stapes footplate, this is the oval window area, and the second genu, the facial nerve, is like superior to the oval window. So these are the landmarks. So Eustachian tube opening, anterior wall, this is tympanic, tensor tympani muscle. It comes and through the cochleariformis, it turns right angle and attaches to the malleus. Now again, another picture. After removal of tympanic membrane, again, this is malleus. This is the chorda tympani nerve traveling between the long process of incus and the malleus. This is incus, incudostapedial joint. This is stapes in, this is oval window. This is the stapedius muscle attaching to the neck of the stapes. This is pyramidal eminence giving rise to the stapedius tendon. And this is the facial nerve, thick bulge. This big bulge is the bulge of basal turn of cochlea called promontory. This is round window covered by secondary tympanic membrane. This is tympanic plexus of nerves formed by the Jacobson's nerves, salsalpetrosal nerves, and the sympathetic nerves from the carotid internal carotid artery. This is the epitympanic area. Now, the facial, this is the, just like we said, the significance of facial recess, that we can reach the middle ear cavity, approach the middle ear cavity, access the middle cavity without disturbing the bony canal, external auditory canal. From behind, we just drill into the facial canal. This is the chordae tympani nerve. This is facial nerve. As you can see, this is the incus. Short process. This is the long process. This is the stapes. This is the malleus into the malleolar joint. Just like the saying, this is the bulge of lateral semicircular canal. The facial nerve is inferior to the bulge of lateral semicircular canal, and this is deep to the short process of incus. This is facial nerve, deep to the short process of incus. Similarly, this is also the picture of mastoidectomy. We have entered the mastoid antrum. We have drilled, thinned out the external auditory canal. This is the horizontal, vertical part of facial nerve. This is the chordae tympani arising from the facial nerve. We have made a hole peeking into the middle ear cavity. This is incus. This is facial nerve. This is lateral semicircular canal. Now, this is again the picture of the left tympanic membrane. This is tympanic annulus, fibrocartilaginous thickening of the tympanic membrane only in pars tensa, not in pars flaccida. This is pars flaccida. This is anterior malleolar ligament, posterior malleolar ligament. Above it, this is pars flaccida. This is notch of Venous. This is handle of Malleus. And this tympanic membrane is tented, fixed at the handle of Malleus at the tip called umbo. From the umbo gives the reflection of light called cone of light, normally in the anterior inferior quadrant. This is the shadow of Eustachian tube, incus handle, stapes. This is round window shadow, and this is all about middle ear. Again, the same picture. This area is attic area, houses the head of the Malleus and the body of Incus. Again, the tympanic membrane is stripped off. This is Malleus. This is Stapes. This is oval in window area covered by the Stapes footplate. This is round window. This is processus cochleoformis. This is tensor tympani tendon. Opening of the Eustachian tube. Do you have any questions? You can type or you can just ask me. No questions? Okay. Now I'll answer to Samir's question. Sir, left and right tympanic membrane same huncha anatomically. Anatomically and structurally it's same, but it's just a mirror image. Exam ma picture draw garnu paryo bhane the questions comes like that. Draw the picture of anatomical diagram, well-labeled diagram of right tympanic membrane. So you should think about the side. Okay, don't draw the picture of right tympanic membrane when it's asked left. So to know the one main thing is just see the cone of light. Cone of light is always in anterior-inferior quadrant of tympanic membrane, and the handle of Malleus is posteriorly tilted posteriorly, and the cone of light is in the anterior-inferior quadrant. So I'll show you. This is the picture of left tympanic membrane. This is the anterior-inferior. This cone of light, the handle of Malleus is tilted backwards. So this is the picture of left tympanic membrane. Chat. Another questions. Inner chat. So the clinical importance of sinus tympani. Gaurav, sir, can you remember mastered ear cells again? So slide I कुछ है ना. Okay. About mastoid ear cells. The mastoid bone is pneumatized during the development into many air-filled air cells. These all air cells comprise of the mastoid air cell system, of which the mastoid antrum is also a part. The mastoid antrum is the largest mastoid air cell in the mastoid bone. So there are three kinds of mastoid, well pneumatized, diploic, and the sclerotic, and all these mastoid air cells are grouped into different locations. We have divided these mastoid air cells for simplifying during the surgery. So I should open as a surgeon all mastoid air cells. I should not leave the zygomatic air cells or the tip air cells or the perisinus air cells. So in the CT scan we can expect where are these mastoid air cells. Some zygomatic air cells are well developed, some the peritubal cells are well developed. So in prior to the surgery we can anticipate which groups are present in the mastoid. Now in my cognitive processor, so we can attend a facial breeze. Sandeep Brownier. Okay. Okay, Sandeep Brownier, facial breeze. Okay, facial breeze is the bony part above the facial nerve, the vertical part of facial nerve, and we open this facial bridge, then we enter the facial recess. So this is the facial bridge, is the bony bridge between the facial recess and the outside. And opening this facial bridge and entering the facial recess is also called posterior tympanotomy. We are entering the tympanic cavity posteriorly without disturbing the external auditory canal. Surgical landmark of facial nerve, sir, please repeat. It's a very simple surgical landmark of facial nerve. First, you see the processus cochleaformis. The facial nerve is superior to the processus cochleaformis. The tympanic part, the horizontal part of facial nerve, then runs along the medial wall, then just above the oval window and inferior to the lateral semicircular canal bulge. Clinical importance of sinus tympani. Now, sinus tympani is a very deep cavity, inaccessible cavity. Through the microscope, to be accessible, to be visualized under the microscope, the cavity should be in the straight line. The sinus tympani does not come on the straight line of our vision. It is a hidden place, it's a deep place. That's why this area is very difficult to clear out of disease. So disease we can leave the disease there. We can see the disease inside the tympanic sinus tympani. The facial recess is also a very might be a deep cavity. It is also a hidden cavity, but we can drill the facial bridge and we can enter the facial recess. So we can visualize and take out the disease from the facial recess. But we cannot approach the sinus tympani in the same way because it is deep to the facial canal, and on the way there comes posterior semicircular canal. So if you want to reach directly access the sinus tympani, we have to drill the facial nerve, we have to injure the facial nerve, then we have to injure or drill the posterior semicircular canal, then only we can reach the sinus tympani. So that is why sinus tympani is very important. The clinical relevance of sinus tympani is that we cannot remove the sinus tympani disease if nowadays sinus tympani disease can be removed easily through the endoscopic ear surgery, where we have the flexibility of visualizing the inside of the tympanic cavity. So nowadays it's not a problem, but previously when there was no endoscopic ear surgeries, this was a very difficult part to remove disease, sinus tympani. Bipana Gurung, sir, right and left tympanic membrane bhanera pani question sodincha ra sodcha. Yes, they ask. And if you draw right tympanic membrane when it's asked left tympanic membrane, then you will get 0. Mastoid ear cell once again. Mastoid